So let's hope we have a fruitful session. Welcome, sir. So we are going to have a session on medical education, entry, exit and training. So we're going to talk about undergraduate, postgraduate education. But we are first going to start by talking about the admission process and the NEET controversy that preceded the formulation of the current policies. So I'll start with that, and then Professor Panda will speak on the need for 5.5 years. Let's have the admission one first. Dr. Grover first.
Good to see someone interested in education. Oh, fantastic. All right. Okay, thank you.
So I'm going to speak about the controversy that was associated with the introduction of the NEET. Now, NEET is the National Eligibility Cum Entrance Test. And it has been perhaps one of the most controversial, debated and resented examination held in India. Is it? And I think some of my subsequent slides will show that. So what was the objective of introducing NEET? The purpose was to reduce multiple examinations for the admission to 412 medical colleges except AIIMS and JIPMA into one single examination. So a candidate who wanted to join medical college MBBS had to appear in multiple examinations, many of them clashing with each other. So this was intended to replace that, and at the same time the secondary objective was to curb the corruption and fraudulent activities in the admission process, which you kept hearing about all the time. So how did NEET come about? So till 2012, CBSE was conducting All India PMT examination for 15% of the All India quota seats, rest conducted by states. And then the government of India, largely on the prodding of Supreme Court, started the process of one country, one test, the NEET. It was, when the concept came, it was opposed by the opposition and from states and from private medical colleges. We know the kind of interests involved in the admission process. So it was no surprise that such a deferring take place, and MCI was entrusted with the task of getting this exam in readiness. So there were over 80 cases filed opposing undergraduate NEET, but in spite of all that, May 5, 2013, the first test was held. But then in July came this much talked about split verdict of the Supreme Court. This was a bench headed by former Chief Justice Altamash Kabir. It held that MCI lacked the legal authority to control admissions to MBBS. Now this was, even though, as I said, the whole process had been prodded by the MCI, by the Supreme Court from the beginning. Now this was a split 2-1 verdict. The possible result was leaked well prior to the said date, and this happened to be the day when Chief Justice was retiring. Following this judgment, there were a lot of questions raised which did not add glory to the court. So as a result of this, CBSE reverted to the conduct of AI-PMT examination as it was doing till 2012. But then a review petition was finally mounted after the Supreme Court Chief Justice Altamash Kabir had retired. This was mounted based on surrounding circumstances and the dissenting verdict of Justice Dave in the 2-1 verdict. In April 2016, the Supreme Court upheld the conduct of NEET for once, reversing its own decision, and revived center's notification for conduct of NEET. It also ruled that any further challenges or classification to the order that they were now passing must come only to SC and not to any other courts. So therefore then the NEET could be conducted in May 1, 2016, but on May 25, Supreme Court under political pressure issued an ordinance that state exams were being kept outside the purview of NEET for the year. Then TN government passed an act in February 2017 saying that NEET will not apply to Tamil Nadu. That has, however, been held up by the center, which has not given a presidential assent to this. So then finally in January 2017, NEET was announced in 10 languages, and Supreme Court allowed addition of Urdu after representations. And then the exam was finally held on May 7, 2017 in one phase. It had been held in 2016 when it did not apply to states in 2 phases first, and then this huge number of candidates appeared, including NRIs, OCIs, PIOs, and foreigners. But this exam was full of controversies. A list of do's and don'ts was released. Metal detectors were used at the exams, and then people had to go and change their jeans or bras, or if there was a metal sound. Earrings had to be cut. Full sleeves were cut to half at places. But there were other controversies as well. There were mix-up in question papers, allegation over attempts to leak question papers, and impersonators appearing for the exam. In May 2017, Madurai bench of Madras High Court stayed declaration of results, but Supreme Court acted proactively and transferred the challenge to itself and directed the CBSE to declare the result. So it seems that NEET was conceived from the beginning by the Supreme Court, given birth, nurtured, and rendered a reality in spite of the hiccups in between, thanks to the interventionist ways of Supreme Court, which have also been criticized by some. But kudos to Supreme Court for its proactive role that in spite of all the odds, it is finally a reality. So that was about the undergraduate exam. Then the postgraduate exam for NEET has also been started. It has been conducted by National Board in 2017 and in 2018. And it is a single entrance exam to various MD, MS and PG diploma courses. It has replaced the DNB entrance exam as well as the All India PG medical entrance examination. It was conducted on January 7, 2018 this year by an online computer-based test in a single day, single session, and the results were declared as recent as January 23, 2018. Now the notice has also come for super-speciality admission test for the postgraduates. So this is proposed to be a single entrance examination to super specialities for postgraduates. It is to be held in June 2018, to be conducted by National Board. A candidate can choose maximum of 2 super speciality courses for which his broad specialty is eligible. For example, a medicine postgraduate can choose gastroenterology and nephrology, but not more than 2, not a neurology also, or no, so he can't give all of them. So this is going to be a computer-based platform, single session, and 40% of questions from the broad specialty and 60% of questions are going to be from the super specialty of his choice. So this is broadly the outlines the struggles that have been that this exam has been through before finally coming to fruition. And hopefully now it will be applied to undergraduate, postgraduate, and super specialty entrance exams, unless some other forces are powerful enough to get back in spite of Supreme Court's active interest.
So why do you think there's been so much opposition to this
We all
NEET?
know the factors, because one is crores and crores and crores. I have been invested in the private medical colleges, and people want to make profits
But
there.
private medical colleges will get students through NEET anyway.
Pardon?
I mean, they will get students through NEET.
Yeah, but they will get students. But earlier they had the privilege, in spite of there being an entrance examination, they had the privilege of admitting the candidates as per their choice. They did not have to be in any merit, so they could take them.
They
Just
could kind of sell those
so
seats.
they could just put in a price, and whoever could pay that price and was an 12th class pass with subjects of biology or something with minimum 40% marks or whatever, could get in. So then they had the freedom to charge whatever they could, and that was the vested interest. But once they have to take people from that merit, they can only take fees which are legitimate. I mean, if you are coming through a merit list, why would you pay a capitation fee?
So there's nothing like a quota, management quota or something like that. No, so that's all finished.
No. Now there will be maybe quotas within that, and the states will admit their own. I mean, from that list, states will have the option. There will be those different categories still exist. There will be central candidates.
Okay.
There will be state
But
candidates.
they all come through the NEET.
Yeah, but those who opt for or a
From
private medical college seats, people have to opt for that. People have to know that they will have to pay those kind of fees if they are opting for private medical colleges. But then they will have to be from that merit list. So if 200 people apply for a private medical college, and then they are in that order of merit, only then they can be selected. So as per the choice. There were efforts to that, and some were caught, and because people use the technique of blocking a seat and something like that. But now that has also been...
What was that block?
35 lakhs per year. Okay. Yeah.
And other students, they will charge less. So, no, does that mean that kind of merit students, they are getting penalized for being in merit? Because they are being charged more.
Yeah. I mean, the NMC particularly totally takes off. There was a Supreme Court ruling on how much the fees per year should be maximum in a private medical college earlier. But now the NMC takes that away. Once the NMC is passed, it says that if the NMC is adhered to, then those 35% seats or so, there will be no limit on what the organization can fix as its fees.
So that will, in a way, again, promote people to come from lower merits to the...
Yeah, but they have to be in that list.
Yeah, but I think there may be like 200 people above them who cannot pay.
You know, what has started happening is that many medical colleges did not get any candidates at all because the fees were too high, so not enough people from the merit list applied. So
No,
that phenomenon for the first time has started happening.
No, that may be
that there were
happening
medical colleges which
not
did not
getting-
fulfill their seats.
Yeah, but that may be happening because people don't want to go to medical colleges. They have better options.
Yeah, you know, the number of candidates that appear is 11 lakh, 32 lakh. So
Okay.
that many people want to appear. Then many more people want it. But they can't afford those kind of fees. And with those kind of fees, they don't want to go into those colleges.
Okay, so someone the lower ranking, if he is willing to pay more fees, so
But then there is a cutoff.
he will be accepted.
But then there is a cutoff that
how
beyond this
low?
you have not
Not yet.
become eligible. It is an eligibility come entrance examination test.
Right.
Huh. Ah. Ah.
That's kind
So
of
percentile will make
it's
it.
very different. Yeah, that's very different.
Yeah. I welcome the two most important speakers. We have an audience here, so you can't say there's no audience. And we'll listen very carefully to every word of what you say. And congratulations on your election. We welcome Dr. Mahipal and Chairman Scientific Committee. So we've spoken about the NEET controversy, how much resistance it faced, and how Supreme Court had to proactively go through those stages in order to fight all the vested interests every year till they got it to fruition. So now we have the undergraduate NEET examination, we have the postgraduate NEET examination, and the super specialty examination is now starting.
I think the specialty you said is kind of based on the similar lines that we have the undergraduate NEET.
Yes. Now again, it will be computer based and will be on desk based, and it will be exam.
Do you think there will be like some differences? I mean, you can't really put the same model everywhere. So do you think in super specialization stage we need a little bit of different model? Because the computer-based
question does arise whether a multiple choice question is the answer to everything, especially in a clinical setting when you're choosing people who have done post-graduation and who want to do super specialization, whether just the multiple choice question which only assesses the theoretical part of it, and that to a specific ability to do well in memorization, do well
just
in
the cognition
reproducing.
part basically,
Yeah. So that aspect must be considered. But yes, at the moment, probably to circumvent the subjective element which has been the bane of all our selection processes so far, which has not been used constructively but has been used with ulterior motives, maybe that is the reason why this has gone through. So maybe then we can have Dr. Pandav speak to us. So then I think in that order.
Dr. Mahipal.
Would you like to speak first? I think
order मेरा.
आप बोल दो सर, इनको settle होने का time दो यार. Audience भी तो चाहिए.
So that guarantees that I have some audience. Okay, my turn. No, Pandav. Thank you very much for this opportunity to speak here. I'm actually representing Dr. Dogra, who had to leave early, so I hope I'm able to do justice to his talk. The question is, do we need 5.5 years MBBS in times of super specialization? Now, before we go to that, to answer that question, I think what are the objectives of the MBBS course? There are a number of objectives. I think there's a detailed document which the MCI has, but I think grossly speaking, we need a comprehensive, MBBS means we are training people for a comprehensive health care who could do a clinical diagnosis, who could provide solutions to health problems, not just the treatment, but the solutions to the health problems of the public, and which also include public education as well as public health. So to perform all these tasks, you basically need a very comprehensive knowledge about not only the human anatomy or the human physiology, but as the human being as a whole holistically, and also the emotional aspects as well as the environment, because health is not just the physical being, is an interaction, is a complex interaction with the biology and the psychology and also the environment. So I think to understand that complex interaction, you really need to be very well aware in all these issues and have your training in these things. So if there's the question, then why are we debating this? That why do we really need to debate this? And so I think this is because with the rise of super specialization, now we have a lot of different kind of doctors. So we have eye doctors, we have kidney doctors, we have liver doctors, And the list goes on, and if you ask public in general, they'll say, okay, now we have the heartless doctors. So I think this is not very unusual to see in public. This one of the aspects is because super specialization is a little bit of glorified and a little bit of glamorized because everyone wants to be in that space. But I think there's a little bit of problem here because it's not really a super specialization. We are still under the same umbrella of MBBS, of that comprehensive care. So unless you are, at that space, only then you can go super specialization. So it's actually a sub-specialization. So we should not be calling it super specialization in that sense. It's a sub-specialization. We are actually going into a very smaller domain. And this increasing trend of, this has resulted in an increasing trend of treating organs rather than humans. So, and that's again is dangerous because the super specialists are very good in a very small field, but their knowledge and domain or its application of that knowledge is very limited. The scope is very limited. So therefore, I would say in this era of super specialization, you actually need more comprehensive doctors who can look more holistically at the patients, because the public health is not just eye disease or a kidney disease. There's a lot more to it, and we need people who can cater to that segment, and which is actually a very wider segment. Now, if you look at the the flow of knowledge and services, because medical field is a very dynamic and ever-evolving field, so there's a lot of knowledge is getting generated, new skills they come, and if you look at there's a kind of pyramid, so it kind of flows from top to bottom. So the new knowledge is created in institutions, which are basically the educational institutions, teaching institutions, the research institutions, and that should go down gradually to the secondary level and hopefully to the primary level. So the comprehensive care doctor, MBBS doctor, he has to be gradually, he should becoming more skilled, and some of the jobs which were done at secondary level, they should actually percolate down to the primary level. And same, there's a knowledge, and same follows the services. So services which are available at tertiary care center, they should become gradually move downwards to the secondary and primary level. But what is actually happening is just the other way around. So those who are in medical institutions, the teaching institutions and bigger hospitals, they see ever increasing rush of patients, and with conditions which could very well be treated at a secondary level, if not primary level. So why is this a reverse trend? Actually, if you go by the logic, it should be, the trend should be other way around, but this is not happening. So what is the reason for that? The reason for this is because the comprehensive care doctors, that knowledge which should flow from top to bottom actually is not flowing in that sense. So the comprehensive care doctors, they are not actually being updated. Now, AIOS, like ophthalmologists are updated through AIOS, heart people, they have their own specialization, kidney have their own societies. So the individual super specializations, they have a mechanism of updating their cadres, but who is doing this for MBBS? So I don't think there's anyone is doing any such conferences at MBBS level. Most of these doctors would be in the government jobs, and they actually have no opportunities to train themselves or upgrade themselves or even motivation to do that. So what is happening is that the skill level, which should be improving constantly, probably is not happening. And when that happens, they will not take up the newer challenges, the newer diagnostic. So, and that also means that the public, because public is very aware these days, so I think there's a little bit erosion in value at that level, and that's why the people are preferring to seek treatment at secondary or tertiary level, thereby burdening those institutions. So I think the problem here is that that means that our MBBS doctors must be empowered. They must be provided more opportunities and more so that they can update themselves, so they are they can take care of the changing needs of the health sector. But what is being proposed here is actually going to reduce the capabilities of the generations of doctors which are going to come, because if you cut down their course to 3 years, obviously you are cutting down on a lot of things. So the comprehensive doctors actually becomes very limited in its capacity, which is already actually restricted. It becomes more restricted. Now that is not a good thing to do, because this will have more consequences. So what's going to happen is that if you look at this is a kind of a spiral, the knowledge and skill is a spiral. So if the comprehensive doctor or MBBS doctor has less skill, less knowledge, 5, 6, 7 years down the line, some of these doctors will move to the apex, because there is no alternate stream of, there's no alternate way of taking people at that level. So some of these people only go to those positions, the research and teaching positions. But if their skill level is already low, so you will have people have a low skill level at the higher. And then this is spiral down to kind of a less skill, less generation of knowledge, less generation of new skills, and less patient care. And that will set up a very vicious kind of a cycle, which will move the primary care upwards and secondary care even upwards to the tertiary care. What will happen eventually, we get even at the tertiary care level, because of the degradation in the skill level, there is going to be people will not be happy there because they will not get the service they should get. So this is going to be very detrimental to the entire health system. So I don't think that's really the way to go. The other thing is that there's going to be loss of parity with the international programs, because the source of knowledge is varied. I mean, a lot of knowledge is generated abroad, and we all go abroad, we do fellowships, we study their programs, we invite them, because there's a parity between their program and our programs. But if our program is substandard, then that cuts off those avenues. So that will restrict the eligibility and opportunities for higher learning in foreign countries and foreign institutions. And the reality is that we depend a lot on other institutions to learn things which we bring back home to India and teach to other students. So this is going to be in the longer very detrimental to the quality of the research education and ultimately to the patient care. So I think a reduction in MBBS courses, to my mind, should never be done. Instead, we should refine it, make it more relevant to the changed environment of practice, changed needs of the society. And what is lacking is actually as in leadership, advocacy, some administrative and research opportunities, which should be built into the MBBS course so that they are better trained to handle the pressures of the administration and the pressures of the public life better. And also to create opportunities for continued learning of doctors at the lower level, because the majority of the healthcare, 80% of the healthcare is actually at that level, not at the tertiary level. So the job of the tertiary level is to create knowledge, to new knowledge, and percolate it down, create skills, percolate down, so that the people where the most of the population lives, they get this benefited. So I think this is how we should go about it. Thank you very much.
Thank you, Dr. Pandav. I think that was very well discussed. On the one hand, there is now a demand that if there are 40,000 graduates coming out, there should be 40,000 postgraduate seats. Then comprehensive ophthalmologist is not left anywhere. I mean, you don't leave a postgraduate.
I think because as it is the MBBS, I think to my mind that should not be done actually. We need that platform, we need that general doctor. But if we want post-graduation, then we have more post-graduation as family practice or a general practice post-graduation.
Yeah, that may be a good idea.
So that means they get a platform.
You provide an opportunity for them to develop it.
Yes, because these doctors, they need to update their service. And what is happening is no one is looking after the interest of an MBBS doctor. So he doesn't belong anywhere. The government doesn't provide an opportunity. The infrastructure is less. They will not get leave to attend a conference. They will not get sponsored for a conference. And also,
where does the primary care go if there is no comprehensive comprehensive?
I mean, these are the ones who do the primary service, primary and secondary level basically. So, and that's where our services are suffering. So, more people from primary level patients, they're going to the secondary and secondary level. They should be treated at secondary level, but they prefer to go to the tertiary level because there is a kind of erosion in value, and that erosion in value has happened because of that lack of continued development of these doctors as professionals, and also the infrastructure, because I think both are lagging.
I think the remedy lies in giving them a better stature and better training, better education to work as comprehensive.
I think, yeah, that's true, but I think stature is something that you can't really give to somebody. That is because that has to happen, and that will happen by your professional conduct. So that means you kind of, again, it comes from empowerment. You empower those doctors, they have to have this.
More CPD
you have to build that confidence.
Continued professional development.
Yeah, we have to build that confidence in that cadre of people. Look, we are doing a job and this is how it is to be done. But that would be done only with the continued education. And once there's a continued education, once they do a good job, they themselves would be in a position to actually demand better infrastructure and create better infrastructure.
Thank you, Dr. Pandav. That was very good.
Thank you, sir.
पहले बोल दो महिपाल पहले ललित की उधर चौक है इसको बोल लेंगे तो ललित will be speaking on the desired essentials of PG training in a surgical specialty. are we addressing it well? So PG training, what essentials it should have in surgical specialties? Are we being able to meet those needs? So let's have his thoughts, and then we'll have Dr. Mahipal speak to us on undergraduate education.
Thank you, sir, for accommodating me early, because this chairperson actually was supposed to be out of Dubai, but he could not come. I'll be sharing my thoughts about what should be done in PG teaching. Are we doing it the right way? You see, PG residency program involves so many things, which are often, especially in this part of the world, taken for granted or are not uniform everywhere. The biggest challenge I think all of us face is that this lack of uniformity. A person doing PG training RP center vis-a-vis doing anywhere else may not be the same. And whenever these people apply for jobs, post-PG or post-fellowship, so anyone doing from big centers, and then or Shankar Mitrale or or even RP center, they get immediate job placements vis-a-vis. So why should these other people suffer for no fault of theirs? Although it's a political move, and it has to be, standardization has to be done. I know Dr. Grover has laid down so much curriculum, and we have represented to ministry also. But ultimately, the bottom line is, in the real world scenario, nothing much I think is happening. The key purpose of residency is an education program with well-defined goals and objectives. Although there are defined goals and objectives available, but believe me, we travel a lot. Routine clinical skill also of residents is vastly different, and a lot needs to be done in these things. Curriculum, I know, sir has prepared a huge curriculum on that, but whether in reality is being done or not, it's just, to my thing, is sad scene. Didactic lectures, seminar, journals, discussions, this is perfectly okay. But are all the departments doing this ocular pathology, ocular microbiology, ocular radiology? Again, not a very happy situation in most of the hospitals. Then surgical skill development, because ophthalmology majority is surgery. Because you see, what I tell all residents is acquire one skill at least, whether it is making cataract good surgery or retina good surgery. So, but are these surgeries being monitored? Are these being done the way should be done? Are all the colleges have hands-on practices on goat's eye? Do they follow such kind of sequences? Do they have simulators, or do they have some video bridging? Believe me, all is theory. Even in big hospitals, resident is made or left to struggle for himself. He may be allotted a case for which maybe a CGHS whatever, and he himself learns, or maybe if he finds a good mentor, maybe he does it. But the way to do is that he goes through this sequencing, so that he learns on, that is what motivated me to start SSTC here. So at least, people learn, have a feel of instrument going, phacoprobe, how to make section, then maybe training on simulators, and then, comes the human eye. And you see, we have to, apart from surgical skill development, a lot of other things have to be imparted to PGs. How they should be carrying out research, because each clinical finding, each clinical thinking is important. Like I remember first time I saw a cyst in retinal detachment, so it motivated me to search. I remember Dr. Garg telling me, go back and read why this cyst has happened. So each critical thing is, so besides surgical skill development, so many other skills needs to be developed in PG. It's not only surgery or diagnostic part. So, and similarly, patient care. You see, you have to balance patient care with education, whatever skill development. But all this medical record keeping is also part of, should also be part of PG teaching also. It's not that you develop those clinical skills and rest is left, because all this future ophthalmologists, or they will require all these things. Similarly, entering of these medical reports, because EMR and medical documentation is becoming very, very important. If people don't document their reports properly, it may become an issue with consumer protection also. Then specific time allotted for community service, although there in most of the places. Then faculty is the primary link between the residents, between the scientific base of medical knowledge and the art of medical practice. But faculty, again, teaching of the teachers also is very important. Faculty should demonstrate clinical experience and current fundamental of knowledge. And that also adequate number ratio, is it there everywhere? Or residents are, sometimes looking for faculty for their classes. So these are, one thing is theory, one thing is real world scenario. So faculty have to have teaching as a passion or a priority also, apart from being accessible, available and good rapport with residents. But they have to realize that their job has to involve teaching and evaluating also. Because periodic evaluation, if you have done one-sided job, but is your knowledge being percolating enough to the residents or not? So this periodic evaluation also is a must. There could be various methods which could be discussed, that how to evaluate. AIOC is one of them. Then ancillary support, also like you see availability of allied optometrists, then sufficient sectorial services. In fact, this I think we are hoping for too much, that in this country this staff may be available. What to talk of the other things. Then residents also, we should realize that they also need some personal time also, because most of the hospital residents are burdened with so much of work, so much of clinical and non-clinical work, that this leaves them little time for their personal jobs, leave time or crisis, or sometimes you see we keep hearing about this suicidal thing, because they are working non-stop for hours and hours. Then availability of educational supplies like computers with access with literature search availability, resident library which should be actually open 24 hours. Although you see books have taken a back seat, and with the availability of Google and everything, everybody wants to search on that. But I personally think that method of teaching was much more valuable than this Google teaching. Then research support also, you see we have to inculcate in our residents about the research part, that how to begin. The funding again is an issue. Now a lot of residents don't enter into research primarily because of these are barriers like funding, time, opportunity, access to faculty, because very few faculty will inculcate research habits in their residents, and access to statistician. Very big hospitals will also not teach statistics part, that how should they evaluate. Even if I am doing say work on Lucentis, but what this data is lying in junk, because somehow my exposure is not there. So believe me, there are a lot of components to PG teaching. It's not only just surgical skill imparting and doing lectures in journal clubs. There are a lot of elements which involve, you see, education, patient care, availability of all these supporting things in the residency program. Thank you very much.
Thank you, Dr. Lalit, for having brought out all the elements that constitute the residency education and for bringing out the perspective in India. We all are aware of the perspective, where I in my editorial wrote that residency education
I read that.
From sublime to ridiculous. So we have to try and bring about a uniformity through some regulator which functions, so that we are able to at least bring it to one level.
Question is, whose job is this?
Yeah, so let's see
Yeah.
whether MCI will exist or not for some days from now, or whether the new body that comes, if it comes.
I know you have been trying to, work in this direction for so many years, but practical dent being made, I have not seen too much.
But I think at least
A step in
the
positive
PG
direction.
teaching programs have started making a difference in the standard.
Yes.
Awareness has increased as to what the aspirational level should be, which
Sir,
is reached.
That has been started by society.
Yeah.
That has started by society.
So at least in ophthalmology, there is a little better awareness in residents as to what the aspirational standards are.
Yeah.
So which is making a difference.
That has happened.
It has changed scenario in 5-7 years.
Ji, ji.
Any questions on that? So let's have Dr. Mahipal speak to us on the undergraduate education. training, teaching, and exposure at undergraduate level, is it uniform and relevant?
Thank you very much, Dr. Grover. Well, I think there is a little that we need to be debating about as regards the uniformity of standard. I think that is the main problem that we have in India, whether it be just a graduation, a school, or whether it be MBBS, or whether it be post-graduation. What is important is that we need to have certain things that need to be of a particular level. Yep. Okay. So when you're looking at UG teaching, when you're looking at ophthalmology, the main thing is that undergraduate is basically the introduction as to ophthalmology, and what we need to see is that the doctors who come out, the general practitioner whom Dr. Panda was just talking about being the link, so they have to be the link for ophthalmologist also. And that is what is very important. So typically ophthalmology is not considered to be a major specialty, but still now I think with the new curriculum they have to pass ophthalmology separately. So that is something very important, and they need to be able to identify certain things which are related to the general medicine and to the what the patient is doing. Now, as you look at the whole thing, this was an article that was written in IGO, and what we say, what was the question that was asked was that are we able to showcase modern ophthalmology to the resident? That is the most important thing, that when you are looking at the teaching and the level of the doctors who are teaching ophthalmology in various medical colleges, are they knowing what new technology is? Are they knowing where ophthalmology is going? And are they able to take this to the undergraduate? So majority of the undergraduate residents do not see even a phacoemulsification system or lasers or modern diagnostic systems. So they get a very primitive kind of a knowledge as to what exactly ophthalmology is, and often it also does not enthuse them enough to make ophthalmology as their choice. So the importance, therefore, why is it important that the ophthalmology training should be of a particular level to the undergraduates? And what we feel is that the first thing is that it should be able to motivate them to kind of know what ophthalmology is. Till they see what ophthalmology is all about, they will not be able to even want to become ophthalmologists. Second most important thing is that they should be having the basic knowledge so that they can refer the patients to a trained ophthalmology. And finally is also they should be able to work on to getting the PG exam cleared. Now if you look,
maybe as medical officers in wherever they are, be a primary eye care.
Yeah, so that's what I'll be just talking. So basically the statistics according to the ICO, there are the number of eye doctors that is there is that they are much less. If you look at the population, there are 29 as compared to 11 per every million in India, and this is a significant lack of ophthalmologists. So until of course you are having this new batch of ophthalmologists coming in, that is not going to take care of the Indian ophthalmology, especially in tier 3 cities and in rural areas. So that is still a problem. Blindness remains a problem. So we need to have ophthalmologists, and this gap can only be filled if we have an upgradation of what is being taught to them. So there is therefore a need to motivate the students to take up ophthalmology, and I don't think anybody will be motivated enough if they are only shown a torch to look at findings and be talked about certain things which are very, very basic. Now the second important thing which you were just referring is the timely referral of a patient to a trained ophthalmology. That is not done. There are ophthalmic signs need to be told to all MBBS people that as a consequence of many systemic diseases, there are ophthalmic signs which need to be looked at, and there are numerous systemic diseases, they have ocular manifestations. And often it is the eye findings which become the first thing at times, which we all know that if you have, for example, the ptosis, you have the leash nodules, so you need to look that this is neurofibromatosis. Even if you can look at thyroid disease, often it's the eye problem which at times is manifestation that you have to see, that you have to get a thyroid examination. One important thing is we are having more babies born prematurely, living their life, and there are even several problems which the people, the medical officers have gone. There are recent litigation charges that have been given to the patient, that they did not even ask for an ophthalmic review, etc., because they were not aware that these are the things that need to be looked at. Other systemic disease, they should be knowing about collagen vascular disease, peripheral ulcerated dry eye, Sjogren's, etc. These things need to be looked at. Diabetic retinopathy is another thing where the doctors have, who MBBS have not seen diabetic retinopathy changes, and they haven't seen enough patients of diabetes going blind. So that basically becomes a problem. So they need to be told and educated, and that has to be done at the MBBS curricular level, and force every diabetic to go in for a retinal examination that is there. Now, if the importance therefore of this second point is that even if they specialize in something else, they should know as to when a person needs to be referred, and a timely referral for an ophthalmic consult is important. And I think the third important thing is to complete the curriculum, and medical education is supposed to cover every part. Even though we are going into super specialization, we need to know the basics of every part of the body, and eye is one of the most important sensory organs, and knowledge on ophthalmology needs to is required to clear the examinations and to qualify for post-graduation. So I think from our little perspective of Center for Sight, we hold a wisdom tree wherein we try to get teachers and professors to come, and we try to bring up their knowledge levels and the skill levels as to what is new that is happening. That is something that needs to be looked at. There has to be continuing education of the doctors who actually are teachers in ophthalmology in various medical colleges. I think even at the AIOS level, these courses should be taken up, whether it is at this particular level or others. And then obviously the credit rating system is still in its infancy. That needs to be every doctor or ophthalmologist who is in the teaching field should need to upgrade, and the trainer needs to be trained. That is something very important. And I think the new technology, whether it is possible or not, but I feel that the ophthalmologists who are undergoing ophthalmology, if the medical college does not have these good kind of equipments or whatever, whether it be the retinal lasers or it be an indirect, even those primitive things, they should at least for a day or 2 or 3 days be given an exposure in any private. So there should be, I feel, a private-public partnership where the doctors are exposed to what else is happening in ophthalmology. Thank you very much for your kind attention. Thank you.
Thank you, Dr. Maipal. So, as he's brought out, that is the core of where you are forming a basis for ophthalmology, and you need them to provide the basic primary care, and you need them to develop into specialists and then super specialists to become the core of our training. So, undergraduate training is definitely important. It cannot be overemphasized. So I think that has been brought out very well by him. Dr. Pandav, any comments on that before we continue?